afternoon, my dear friends, my colleagues. Today we will start a new presentation, my lectures related on topic drug-induced kidney injury. Previously I have conducted lectures drug-induced liver injury, and why it's important? Because so many classes of drugs is class-specific effects has drug-induced injury, and later we will talk about drug-inducing heart injury, and we will go ahead and we will discuss toxicity of drugs and how to prevent these drugs, how management, conduct management of this condition. For our colleagues, for our new colleagues, let me introduce myself. My name is Galina Cordero. I am qualified person pharmacovigilance, head of pharmacovigilance department, clinical expert, GVP.Farmak. We will talk about this condition because, as we know that and kidney injury condition, it's pathological condition as a liver injury condition. It can have terminal condition with death, and it's lethal, and so many problems it can be if it is not taken account condition of patients. Later I will talk about higher risks drugs in specific special groups for patients with liver problems, diseases, and heart diseases and kidney diseases, and how manage. But when we see that even if a patient is healthy with kidney, does not have no problem diseases with kidney or liver, they can have drug-induced injury. I think that it can be important for precisely for medical doctors, for pharmacists who meet this situation in daily practice. The kidney maintains the vital function of clearing excess body fluid and removing metabolic and exogenous toxins from the blood. The kidney is particularly vulnerable to drugs and other agents that cause renal damage. The heart pumps approximately 25% of cardiac output into the kidneys. Any drug in the blood will eventually reach the highly vascularized kidneys. May potentially cause drug-induced renal failure if the drug is primarily cleared by the kidney. The drug will become increasingly concentrated as it moves from the renal artery into the smaller vasculature of the kidney. The drug may be filtered or secreted in the lumen of renal tubulus. The concentrated drug exposes the kidney tissue to far greater drug concentration per surface area. Drug-induced kidney failure is a major adverse event associated with multiple medication classes medication as diverse as OTC analgesics, ibuprofen, acetaminophen, antibiotics, and chemotherapy agents can cause kidney damage. Medication use accounts for 2% of hospital admissions for acute renal failure and up to 15% of admissions into intensive care. Nephrotoxicity exert toxic effects. Evaluation criteria to consider stopping agents of nephrotoxicity. Evaluation criteria to consider stopping agent due to nephrotoxicity relative to serum creatinine increase 50% over baseline. Absolute serum creatinine increase, serum creatinine baseline less 2 milligram per deciliter, creatinine increase 0.5 milligram or deciliter over baseline, and serum creatinine baseline more than 2 milligram per deciliter, creatinine increase 1 milligram per deciliter over baseline. Nephrotoxic drugs, there are so many drugs with nephrotoxic effects, and we will talk now about main groups and with group drugs, with representative of this group of drugs, and pathological mechanism of renal injury, because we will see that so many can be conditioned. For example, even we will talk about analgesics, it's acetaminophen, aspirin, it's chronic interstitial nephritis, and when we talk about it, we should remember that this group of drugs, when we go to previously lectures, it's and drug liver-induced injury can be caused as syndrome Ray. Why I pay you attention? Because this group has an kidney can be reason cause of kidney injury, drug-inducing kidney injury, and drug-inducing liver injury. And this group, another group, it can be non-steroidal anti-inflammatory drugs, ibuprofen, as for example. It's can be cause of acute interstitial nephritis, altered intraglomerular hemodynamics, chronic interstitial nephritis, and glomerulonephritis. Antidepressant and mood stabilizers, amitriptyline, for example, Elavis, doxepin, zolanon, and fluoxetine. Prozac. Prozac is medicine, for example, in United States, very frequently administered for patients. This group, it's why I pay you attention that this drug can have nephrotoxic effect too. For example, it can be cause rhabdomyolysis too. Lithium, it's chronic interstitial nephritis, glomerulonephritis, rhabdomyolysis. Antihistamines, for example, it can be diphenylhydramine, Benadryl, doxylamine, Unisom, can be cause of rhabdomyolysis. Antimicrobials, acyclovir, Zovirax, acute intestinal nephritis, crystal nephropathy can be cause of this condition. Aminoglycosides. These classes of antibiotics is enough old one classes, and beside of nephrotoxicity, this group can have and ototoxicity too, and we should remember about it. When we talk about nephrotoxicity, aminoglycosides can be cause of tubular cell toxicity. Amphotericin B, for example, it can be fungizone, deoxycholic acid formulation, more so than the lipid formulation, can be cause of tubular cell toxicity. Beta-lactams, penicillin, cephalosporins, can be cause of acute intestinal nephritis, glomerulonephritis, and penicillin. Furcarmet, foscavir, crystal nephropathy, tubular cell toxicity can be cause of this pathological condition. Gangiclovir, citavan, can be cause of crystal nephropathy too. Pentamidine, pentam, tubular cell toxicity can have pathological mechanism of renal injury. Quinolones, acute intestinal nephritis, crystal nephropathy, and remember about ciprofloxacin. These classes, quinolones, can influence on congestive tissue too, and please pay attention to this condition, because medical doctors, pharmacists should monitor new information and SMPC and patient leaflet. And if you, for example, have any question about SMPC, how monitor, you can ask me and I will give you information where you can find it, because you can find this information out there, outdated safety profile of drugs in sites of regulatory authorities. Plus there are, for example, when we talking about English SMPC, it's Medicine for UK. You can use this site. Plus, why we talking about now strict relation between medical doctors, practitioner, healthcare professionals, and pharmaceutical industry. As a pharmacovigilance specialist, I just want to remind you that pharmacovigilance specialists, now medical writers, write periodic safety update reports and risk minimization plans, RMP. These documents with new risks of drugs. Plus, you can monitor PRAC sites, and every month this community with related with European Medicine Agency have meeting and conduct meeting and discusses new risks of drugs with proposals how to minimize these risks. And CPIT practitioner, healthcare professional, medical doctors, pharmacists don't have ability to monitor the sites, and plus literature, there are, I just want to remind about MBase, about MBCO, about Pharmpendium, about ability to find new information of safety profile. What I'm doing, I monitor this information. You can find it on my profile in LinkedIn, and you can leave your needs in you can leave needs on the YouTube channel too with your questions, and I will be thankful. It's my honor be thankful for your question and will be helpful for your practitioner needs. We will continue these topics. We will go for rifampicin, rifandin, it's acute intestinal nephritis, sulfonamide, acute intestinal nephritis, crystal nephropathy, vancomycin, acute intestinal nephritis, antiretrovirals. This class of drugs have tubular cell toxicity. It's adenavir, hepcera, cidofovir, vistit, tenofovir, variat. When we talk about benzodiazepines and calcinum inhibitors, it can be rhamdomyolis, and it's enough critical conditional. Plus, when we're talking about cardiovascular agents, it's angiotensin converted enzyme inhibitor, angiotensin receptors blockers. About this class I can talk a lot, because first of all, angiotensin converted enzyme inhibitors can cause cough, and many medical errors from physicians is treatment on chronic bronchitis in this group of patients, but because of influence of bradykinin, angiotensin converting enzyme inhibitors can cause of cough, and you please pay attention on it. Plus this group of drugs, be careful in first semester of pregnancy too, and edema can be caused too, and this group differently acted in differently genetic population. I will talk about it in my new lectures. Genetic polymorphism can have. When we will talk about cardiovascular agents, and we will talk about nephrotoxicity, its altered intraglomerular hemodynamics can influence clopidogrel, Plavix, tickled thrombotic microangiopathy. Please pay attention, because from one side this drug, clopidogrel and ticklopidine, very wide with a big frequency administered in patient. Plus remember about this other event is thrombotic microangiopathy. Statins, rhamdomyolis. It's rhamdomyolis, as you see, have many groups of drugs, and it's a very severe condition. It can be fatal effect. Chemotherapeutics, carmustine, glidadel, cevustin, now investigational drugs, chronic intestinal nephritis, ciplastine, platinol, chronic intestinal nephritis, tubular cell toxicity, interferon alpha. Intron A can be cause of glomerulonephritis, methotrexate, crystal nephropathy, mitomycin, thrombotic microangiopathy, tubular cell toxicity. Contrast dye, tubular cell toxicity, diuretics, lupus thiazidis, acute intestinal nephritis, triamterene direnium, crystal nephropathy, drugs of abuse, cocaine, heroin, ketamine, ketalar, methadone, methamphetamine, can cause of rhabdomyolis. Herbals, and please pay attention, because when we talking about traditional Chinese medicine, Chinese herbals with aristocolic acid can be cause of chronic intestinal nephritis. Proton pump inhibitors, lansoprazole, Prevacid, omeprazole, Prisonac, pantoprazole, Protonix. We remember about influence on magnesium exchange, and this hypomagnemia will not stop it while you will not interrupt administration of this group of drug, proton pump inhibitors. Plus it can be cause of acute intestinal nephritis. Others groups, zolaparinol, zolaprim, acute intestinal nephritis, gold therapy, glomerulonephritis, haloperidol, haldorhabdomyolis, pamidronate, aredia, glomerulonephritis, phenatin, dilantin, acute intestinal nephritis, quinine, qualidin, thrombotic microangiopathy, ranitidine, Zantac, acute intestinal nephritis, isolindronate, Zameta, tubular cell toxicity. We see that which pathological condition can happen related with nephrotic the kidney injury, and with this toxicity related with kidney. Clinical recommendation: a patient at high risk of drug-induced nephrotoxicity, those with one or more of the following age older than 60 years, baseline renal insufficiency, GVR less than 60 ml per minute per 1 0.73 meter volume depletion, multiply exposures to nephrotoxin, diabetes, heart failure, and sepsis. Evidence rated C. Access baseline renal function uses the MDRD or Cockcroft-Gault GFR estimation equation and consider a patient renal function with prescribing a new drug. Its evidence rating C. Monitor renal function and vital signs after starting or increasing the dose of drugs associated with nephrotoxicity, especially when used chronically. Evidence rating C. Drug-inducing renal impairment is generally reversible provided the nephrotoxicity is recognized early in the offending medication is discontinued. Evidence rating C. And we will go and we will ahead and we will talk about drug kidney injury. Shortly it sounds as DKI. It's a new onset of kidney injury or the worsening of an existing kidney injury due to drug administration. Drug-induced nephrotoxicity, DIN. Drug-induced nephrotoxicity is a common complication of several diagnostic and therapeutic agents and can manifest as acid-base abnormalities, electrolyte imbalance, urine sediment abnormalities, proteinuria, pyuria, and hematuria, decline in the glomerular filtration rate, GFR, rise in the serum creatinine, CR, and blood urea nitrogen, BUN. Epidemiology of this condition. When we talk about, we'll have information from open source, we see that 20% of hospital admission due to AKA, acute kidney injury, are drug related. Most of them are community acquired. AKA 7% of hospitalized patients, 20-30% of critically ill patients, significant source of morbidity and mortality. Up to 25% of our cases are attributed by use of certain drugs. The classification based on the mechanism of pathogenesis of toxicity of drugs related, and you see that it can be toxic kidney injury, direct toxicity, acute interstitial nephritis, AREN due to allergic mechanism, intensivity, and direct toxicity, indirect toxicity such as electrolyte abnormalities and decrease of renal blood flow, and obstruction of urinary tracts. When we see and we talk about the classification based on the damage of segment of kidney, it can be glomerular injury, tubular injury, interstitial injury, and vascular injury. What kind of injury pattern involved in this pathological process? It can be subtitle injury of overt renal failure. Some drugs perturb renal reperfusion and induce loss of filtration capacity. Others directly injure vascular, tubular, glomerular, and intestinal cells. Specific loss of renal function lead to clinical findings. It can be microangiopathy, acute tubular necrosis, acute intestinal nephritis, nephrotic syndrome obstruction, nephrogenic diabetes insipidus, electrolyte abnormalities, and chronic renal failure. True incidence of DIN is difficult to determination. True incidence of DIN is difficult to determine. Markers of early injury are being investigated. Detection is often delayed until an over change in renal functional capacity is measured as increase in BUN CCR. Subtitle renal damages associated with medication are frequently unrecognized. Tubulopathy, acid-base abnormalities, electrolyte imbalances, and disorders of water balance, and mild urinary sediment abnormalities. Renal pathophysiological alteration drug-induced can be tubular epithelial cell damage. It can be acute tubular necrosis, osmotic nephrosis. It can be hemodynamically mediated kidney injury, obstructive nephropathy, intratubular obstruction, nephrolithiasis, glomerular diseases, tubal intestinal disease, acute allergy, intestinal nephritis, chronic interstitial nephritis, nephrocalcinosis, papillary necrosis, glomerular disease, tuberintestinal disease, acute allergic intestinal nephritis, chronic intestinal nephritis, papillary necrosis, nephrocalcinosis, renal vasculitis, thrombosis, a cholesterol emboly. That can be vasculitis and thrombosis, a cholesterol emboly. First, tubular epithelial cell damage caused by either direct toxic or ischemic effects of drugs, damaging localized in the PC8-DC8 epithelia. Acute tubular necrosis observed as cellular degeneration and sloughing from PC8-DC8 basement membranes, and osmotic nephrosis, swelling and vacuolization of proximal tubular cells. And now I propose we will go and characteristic of class-specific nephrotoxicity. We will start about aminoglycoside nephrotoxicity. Aminoglycoside nephrotoxicity incidence 5 to 15% of patients receiving aminoglycoside therapy. Clinical presentation can be gradual progressive rise in CCR and CRCL after 6-10 days of therapy. Non-oliguria more than 500 milliliter per day. Magnesium wasting more than 10 to 30 milligrams. Severe kidney injury does not usually develop. Pathogenesis and aminoglycoside nephrotoxicity, binding, intracellular transport in lysosomes, release of lysosomal enzymes, ROS, its active radicals generation, altered cell metabolism and membrane fluidity, cellular dysfunction and death, PC8 epithelial cell damage leading to obstruction of the tubular lumen, back leakage of the glomerular filtrate across the damaged tubular epithelium, and reduction of GFR. Risk factors: aminoglycoside nephrotoxicity. It can be aggressive aminoglycoside dosage, combination of a nephrotoxic drug therapy, and existing predisposing conditions. Prevention: how to prevent this nephrotoxicity? It's alternative therapy. Use fluoroquinolones, 3 or 4 generation cephalosporins. Limit the total aminoglycoside dose administered. Avoid concomitant therapy with other of nephrotoxic drugs, and higher intermittent doses once daily doses regimen. Management of this condition, aminoglycoside nephrotoxicity, it's measured CCR every 2 to 4 days. Maintain adequate hydration, avoid volume depletion. Discontinue or revise the regimen if a CCR increase of 0.5 milligram deciliter or more, and short-term dialysis. Another specific nephrotoxicity, we will talk about amphotericin B nephrotoxicity. Amphotericin B nephrotoxicity incident toxicity related cumulative dosage starts from 300-400 milligrams to 4 gram. At higher doses it can be 80. Incidence Clinical presentation: renal tubular potassium, sodium and magnesium wasting, impaired urine concentratability, distal renal tubular acidosis, decrease in renal blood flow on GFR, a rise in CCR and BUN. Pathogenesis and phototoxic nephrotoxicity. Pathogenesis is increased tubular permeability, consequent increase in energy of oxygen requirements of epithelial cells, reduced cellular oxygen delivery due to renal vasoconstriction, renal medullary tubule epithelial cell necrosis, and kidney injury. Risk factors: amphotericin B nephrotoxicity, ECKD, higher average daily doses, volume depletion, concomitant administration of diuretics, and rapid infusion rate. Yes, we should think about prevention of nephrotoxicity too, and you should understand pathophysiological mechanism when you're talking about nephrotoxicity in general, and you should remember about liposomal amphotericin B formulation, targeted drug delivery for infusion of NC daily during the course of therapy, reduce toxicity management, discontinuation and substitution of therapy, daily monitoring of renal function indices, i.e. CCR and BUN, daily monitoring of serum magnesium, potassium and calcium concentration. Another one group, ceplastin and carboplatin nephrotoxicity, is ceplastin and carboplatin nephrotoxicity incident. Previously, incidence was 50-100 percent. Now it was reduced to 16%. 20 to 40 decline in GFR is frequently observed. Pathogenesis of this group of this nephrotoxicity is binding of PCT cell proteins and sulfhydryl groups, disruption of cell enzyme activity, uncoupling of oxidative phosphorylation. Initially, PCT is damaged, which progresses to DCT and glomerular necrosis. Ceplastin and carboplatin nephrotoxicity clinical presentation: CCR reaches a peak after 10-12 days of therapy, which recovers in 21 days. Dose-related toxicity, cumulative response of subsequent cycles, hypocalcemia and hypokalemia, hypomagnesemia associated with the seizures, neuromuscular irritability or personality changes as persist long after chemotherapy. Risk factors: its age, dehydration, renal irradiation, concurrent use of aminoglycoside antibiotics, and alcohol abuse. Prevention of ceplastin and carboplatin nephrotoxicity is dose reduction and decreased frequency of administration, combination with other safer chemotherapeutic agents. Vigorous hydration maintains 100 ml per hour of urine output. Start 24 hours prior therapy, 250 ml per hour 1 to 4 of NS. 8 hours after dose, 150 to 250 ml per hour. Amifostine, organic thiophosphate, and helictis. Ceplastin in normal cell reduces nephrotoxicity, neurotoxicity, ototoxicity, and myelosuppression. Management: ceplastin and carboplatin nephrotoxicity. Ceplastin-induced AK is particularly reversible. Daily monitoring of renal function indices, CCR and BUN. Daily monitoring of serum magnesium, potassium, and calcium concentration. Electrolyte correction, pyramid, supportive care, and dialysis. Osmotic nephrosis is pathological condition refers to structural changes that occur at the cellular level in nephrons. A morphological pattern with vascularization, swelling, and ultimately necrosis of the renal proximal tubular cells. Several drugs are associated. It can be mannitol, LMV, dextran, radiographic contrast media, drug vehicles such as sucrose, propylene glycol, immunoglobulin solution, plasma volume expanders, hydroxyethyl starch. Pathogenesis: renal vasoconstriction, osmotically inducing afferent arteriolar constriction, reduces blood flow and GFR. Management: discontinued in therapy, diluted the solution of reducing the rate of infusion, hemodialysis. It's how manage this condition too. Managing osmotic nephrosis include discontinued therapy, dilution the solution of reducing the rate of infusion, and hemodialysis. Causative agents can be ICA inhibitors, angiotensin II receptor blockers, nonsteroid and anti-inflammatory drugs. It can be selective COX-2 inhibitors, cyclosporin, tacrolimus. Clinical presentation of this condition: kidney injury can occur with days of initiation therapy. When we're talking about NSAIDs and nonsteroid anti-inflammatory drugs, it can be diminishing urine output, weight gain, and or edema. Urine volume and sodium concentration are usually low, and BUN, CCR, and potassium are typically elevated. Cyclosporin, tacrolimus, sclerosis, CL can be decreases, and can be hypertension, hyperkalemia, sodium retention, and hypomagnesemia may occur too. Laboratory value, when we're talking about ICA and RBC, is acutely reduced GFR dose-related condition, normally moderate rise of 0.1 or 3 mg per deciliter, detrimental cases more than 1.5 mg per day in 1-2 weeks, and can be hyperkalemia. Management of this condition can be discontinued therapy, management of severe hyperkalemia, caution combined NSAIDs of COX-2 inhibitor and ICA of RBC therapy is contraindicated. Obstructive nephropathy can be intratubular obstruction, intratubular precipitation, acute oliguric or anuric kidney injury, nephropathy, dysuria, urinary frequency, back and flank pain, clinical manifestation, tumor lysis syndrome, chemotherapeutics, urine uric acid creatinine more than 1, rhabdomyolysis, intratubular precipitation of myoglobulin, and B-hydroxymethylglutaryl coenzyme reductase inhibitors. Glomerular disease. A hallmark of glomerular injury can be proteinuria, patches of glomerular sclerosis, interstitial inflammation, fibrosis. Clinical manifestation: it can be focal segmental glomerular sclerosis, membranous nephropathy, direct toxicity, immune complex formation. Tuberous-intestinal diseases: formation of renal calculi of kidney stones, occur as a result of abnormal crystal precipitation in the renal collected system, intratubular precipitation of crystal material. Prevalence of drug-induced nephrolithiasis is 1%. Signal symptoms can be pain, hematuria, infection, or occasionally urinary tract obstruction with kidney injury. Drugs which can be cause of this condition is triamterene, sulfadiazine, acetylsulfadiazine, crystalluria, Indinavir, antiviral drugs as neflavinaril and forcarnet, antibacterial agents XNP, cyclofloxacin, amoxicillin, and nitrofurantoin, products containing ephedrine, norepinephrine, pseudoephedrine. Management: stop using causative agent, and high urine volume urinary alkalization to pH more than 7.15 may be protective. Intratubular precipitation drugs. It can be acyclovir, oliguric patients, sulfadiazine, ascorbic acid, higher doses, methotrexate in acidin urine, low molecular weight dextran therapy, triamterene foscarnet, calcium foscarnet salt crystal, and indinavir. Management of this condition can be administering the drug after vigorously prehydrating the patient, maintain the higher urine volume and urinary alkalization. This condition characterized by extensive tubulointestinal precipitation and deposition of calcium phosphate, marked tubular calcification. Risk factors can be hypercalcemia, hyperparathyroidism, increases bone turnover, hypercalcemia of malignancy, and increased intake of calcium or vitamin D, prolonged intestinal transit, oral sodium phosphate solution along with concomitant volume depletion. Clinical manifestation: low-grade proteinuria. Causative agent can be diuretics, nonsteroid anti-inflammatory drugs, ICH, angiotensin blocker of enzyme, and RBC group drugs. Popular necrosis: chronic tubulointestinal nephritis, necrosis of the renal papillary region where the collected ducts enter the renal pelvis. Risk factors: its cumulative consumption of combination analgesics as phenacetin or acetaminophen and aspirin, caffeine in combination analgesics and causative agents analgesics generally. Chronic excessive consumption of combination analgesics, especially containing phenacetin, evolves insidiously over years. Its long treatment, difficult to recognize, misunderstood as cause of ACRD. Diagnostic criteria is historic of chronic daily habitual analgesic ingestion, intravenous pylorography, renal ultrasound of renal computed tomography, imaging papillary calcification. Clinical manifestation: pyuria, microscopic hematuria, and low levels of proteinuria, hypertension, and atherosclerotic cardiovascular disease. Prevention of this condition can be limited the total dose, avoiding combining use of two or more analgesics, and maintaining good titration and steroid anti-inflammatory drugs. Management: cessation analgesic consumption, monitoring of renal function indices. Chronic interstitial nephritis is a progressive irreversible lesion. Causative agents can be lithium, cyclosporin, aristocolic acid, Chinese herb, nephropathy. Lithium toxicity. Long-term lithium therapy is associated with nephrotoxicity, impaired ability to concentrate urine, nephrogenic diabetes insipidus, distal renal tubular acidosis. Clinical presentations can be polydipsia, excessive thirst and polyuria, excessive urination, acute tubular necrosis, acute lithium toxicity, proteinuria, a few red and white blood cells, and granular casts. Nephrotoxicity may develop indically and only be recognized by rising BUN or creatinine concentration of the onset of hypertension. Pathogenesis: decrease in collected dust response to antidiuretic hormone. Management of this condition: discontinuation of lithium therapy, amiloride 10-20 mg daily during continued lithium therapy, adequate hydration, avoidance of the nephrotic agents. Cyclosporine Delayed chronic interstitial nephritis has been reported after 6 to 12 months of therapy. Clinical manifestation is biopsy finding include arteriolar hyalinosis, glomerulosclerosis, and striped pattern of tubular intestinal nephrofibrosis, sustained renal, arterial, and endothelial cell injury, increased AT1, decreased nitric acid, decreased tumor TGF-B. Aristofolic acid, Chinese herbal nephropathy, certain weight loss treatment containing Chinese herbs, Aristocholia guan-fang known to contain alkaloid aristofolic acid. Majority of cases are women, develops with 6 to 24 months of exposure. Clinical presentation, mild to moderate hypertension, mild proteinuria, glucosuria, anemia, and shrunken kidneys are also common initial presentation. Acute allergic intestinal nephritis, an allergic hypertensive response characterized as intestinal infiltrate of lymphocytes, plasma cells, eosinophils, and occasional reform polymorphonuclear neutrophils. Pathogenesis of this condition, cell-mediated immune mechanism, predominantly T-lymphocyte infiltrate, humoral antibody-mediated mechanism, presence of circulated antibody to drug tubular basement membrane complex, low serum complement levels, deposition of IgG and complement in tubular basement membrane. Clinical manifestation, rare extrarenal symptoms, it can be fever, rash, and eosinophilia, proteinuria, more than 3.5 gram per day. Managing this condition, discontinue causative drugs, prednisone therapy, initial dose of 1 mg per kilogram per day for a week, which is then tolerated over 3 weeks to discontinuation. Vasculitis, inflammation of blood vessels, can be immunological reaction, can be clinical manifestation, cutaneous, renal, and pulmonary vasculitis, propyltyrosine hydralazine, cutaneous, renal, and hepatic vasculitis, allopurinol, cutaneous, renal, pulmonary, and gastrointestinal vasculitis, isotretinoin, systematic polyarthritis nodosa, minocycline, anti-neutrophil cytoplasmic antibody positive vasculitis, it can be hydralazine, propyltyrosine, allopurinol, and penicillamine, higher titer of anti-myeloperoxidase antibodies. Signs and symptoms of vasculitis, hematuria, proteinuria, reduced renal function, hypertension, withdrawing and offending drugs, tolerating course of prednisone. Thrombosis, formation of presence of thrombus, clot, coagulated blood attaches in blood vessel, thrombotic microangiopathy. Endothelial proliferation, thrombus formation in the renal and CNS vasculate, clinical manifestation, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura. Drugs, metamicin, oral contraceptives, cyclosporin, tacrolimus, Muramanab CD3. When we're talking about oral contraceptives, be careful because this class, besides of thrombosis, can have hepatotoxic effect, and it can be cause even of cancer of liver. It's why women who taking this drug should control and be careful about thrombosis and ALT, AST, alanine transferase, and function of liver to control, because it can be even fatal effect. And about thrombosis, there are a group of risks of women who should pay attention on this condition, thrombosis too. Antianaplastic agents, interferon, ticlopidine, clopidogrel, emtricitabine, and quinine can be cause of thrombosis too. Cholesterol emboli, abnormal particle air bubble clot circulating in the blood, drugs, anticoagulant, thrombolytics, for example, warfarin. Pathogenesis of this condition: aortic arteriosclerotic plaque, embolized cholesterol particles, small arteries and arterioles, inflammatory obliterative vascular response, renal ischemia, signs and symptoms, purple discoloration of the toes, hematine skins over the legs. The criteria for the diagnosis of inducing kidney injury: new onset of kidney injury after the start of administration of the candidate agent A, improvement of stoppage of the progression of the kidney injury after the cessation of the candidate agents. Patient-related risk factors of the drug-induced nephrotoxicity: absolute and effective intravascular volume depletion, age older than 60 years, diabetes, exposure to multiply nephrotoxins, heart failure, sepsis, underlying renal insufficiency, glomerular filtration rate less than 60 ml per minute per 1.73 meter quadratic. Patient-related risk factors and specific prevention strategies for selected doses. When we're talking about drugs altered intraglomerular hemodynamics, ACE inhibitor, RBS, NSAIDs, its underlying renal insufficiency, intravascular volume depletion, age older than 60 years, concomitant use of ACE inhibitors, RBS, and NSAIDs, cyclosporine oral, and tacrolimus prograf. Prevention strategy include use analgesics with less prostaglandin activity, as acetaminophen, aspirin, sulindac, klinapril, nabutenofen, relafen, brand not available in the United States. Correct volume depletion before initiation of drugs, especially if used of a chronic basis. Monitor renal function and vital signs following initiation of dose escalation, especially if uses it risk patients. Cyclosporine tacrolimus is above plus excessive dose. Concomitant use with other nephrotic drugs of drugs that inhibit cyclosporine of tacrolimus metabolism, and prevention strategies: monitor serum drug concentration, renal function, and use lowest effective dose. Aminoglycosides, drug associated with tubal cell toxicity, underlying renal insufficiency, duration of therapy more than 10 days, throws concentration more than 2 mg per milliliter, concomitant liver disease, hypoalbuminemia. Measures to prevent this condition: use extended interval doses, administered during active period of day, limit duration of therapy, monitor serum drug levels and renal function 2-3 times per week, maintain throw levels less or equal to 1 microgram per milliliter. Amphotericin B fungizone, brand not available in the United States. Underlying renal insufficiency, rapid infusion, large daily dosage, dexacholate formulation more so than lipid formulation, prolonged duration of therapy. Measures for prevention this condition: saline hydration before and after dose administration. Consider administering a continuous infusion over 24 hours. Use liposomal formulation. Limit duration of therapy. Contrast dye: underlying renal insufficiency, age older than 70 years, diabetes, heart failure, volume depletion, repeated exposure. Use of low osmolar contrast in the lowest dose possible and avoid multiply procedures in 24 to 48 hours. 0.9 saline of sodium bicarbonate. Withhold NSAIDs and diuretics at least 24 hours before after procedure. Monitor renal function at 48 hours post-procedure, and consider acetylcysteine pre-procedure. Drug-related factors in interaction. Drug-related factors include inherent nephrotoxin potential, dose, duration, frequency and form of administration, repeated exposure. Drug interaction combine and closely associated use of diagnostic of therapy agents with added of synergistic nephrotoxic potential radiocontrast agents, aminoglycosides, NCH, cyplastine, and ICA. When we're talking about patient-related factors too, you should pay attention again of age, sex, and race, including genetic polymorphism, pre-existing renal disease, specific disease, diabetes mellitus, multiple myeloma, proteinuric patient, sodium retaining state, cirrhosis, heart failure, nephrosis, dehydration and volume depletion, acidosis, potassium, magnesium depletion, hyperuricemia, hyperuricuria, sepsis, shock, renal transplantation. We talk about analgesic nephropathy. It is injury to kidney caused by analgesic medication such as aspirin, phenacetin, paracetamol. The term usually refers to damage induced by excessive use of combination of this medication. The specific kidney injuries induced by analgesic and renal papillary necrosis and chronic interstitial nephritis. Aspirin and other NSAIDs are inhibitor of the cyclooxygenases, which results in decreased PGA2 concentration, causes a reduction in blood flow. The deeper structure of the kidney are more sensitive to decreased blood flow, therefore rather selectively damage the renal papilla, increasing the risk of renal papillary necrosis. When we talk in drug associated with crystal nephropathy, it can be acyclovir, Zavirax, methotrexate, sulfantibiotic, triamterene, volume depletion, underlying renal insufficiency, excessive dose intravenous administration, and for prevention, discontinue or reduce dose, ensure adequate hydration, establish higher urine flow, and administer just orally. Contrast-induced nephropathy. It can be another topic because I will talk about contrast-induced nephropathy, and I think what about you should pay attention that this diagnosis group of drug and what I met in my daily practical activity as QPPV and pharmacovigilance expert, clinical expert, that this group of drug need prevention of nephropathy, and because of higher osmolarity, patient should enough to be hydrated. It can be previously hydration before procedure. And what problems that as a diagnostic drug, not every medical doctor who conducts this procedure in MRT, for example, pay attention of it. And you should remember that of this procedure for using contrast-induced agents, and can be a date contrast group of drugs. They don't pay attention that it can be a group patient with endothelium injury. It's a group of hypertensive disease, it's a group of diabetes mellitus, it's a group of patients with ischemic, for example, disease, and problems with heart, and with higher coagulation. And if, for example, this patient diuretics and dehydration conditions, this group of patients with high risk of adverse events of this group. Plus, you should remember from my practice, I pay you attention, it will be another, I pay attention lectures, but I stop in it, that interaction between beta adrenal blockators and contrast-induced drug, because it can be cause of anaphylactoid reaction, like bradycardia. It's can be like masking this condition. Why it's important? Because, for example, contrast-induced nephropathy, it can be enough severe condition, and you should remember that contrast-induced nephropathy is reported to be the third most common cause of acute renal failure is hospitalized patient too. The type and dose of contrast using in presence of acute renal failure risk factors and other comorbidities. The risk of contrast-induced nephropathy is highest in patients with chronic kidney disease, a GFR of less than 60 ml per minute per 1.73 quadratic meters, especially in presence of diabetes. Other risk factors include dehydration, and I pay you attention, dehydration. Patient should be rehydrated previously for prosody. Condition is heart failure, age older than 70 years. It's related with endothelial dysfunction, and you should pay attention on this group of risk, because it can be masked even like cardiogenic shock, anaphylactoid shock, but you should be ready for this condition, because if you have this information, you can prevent this condition or minimize risk of development of adverse reactions. And concurrent use of nephrotoxic drugs should, as a practitioner, collect anamnesis of disease, anamnesis of life, asking what kind of diseases they have, what kind of concomitant drugs the patient taken, and it can be pay attention exactly on nephrotoxic drugs. Patients with risk factors for contrast-induced nephropathy, especially those who have multiple risk factors, require prophylactic intervention before imaging. Prophylactic intervention studied have included normal saline or sodium bicarbonate infusion and acetylcysteine before and after imaging. The role of acetylcysteine has yet to be defined because the clinical trial results have been inconsistent. Renal complication of administration of NSAID, I collect this information from open source. It can be prerenal azotemia, acute tubular necrosis, acute papillary necrosis, acute interstitial nephritis, chronic tubulointerstitial nephritis, analgesic nephropathy, minimal change disease, membranous nephropathy, hyperkalemia, metabolic acidosis, hyperonemic hyperdysteronemism, hyponatremia, and hypertension. Chemotherapeutic agents so many drugs it include. We talked about, I just pay attention of this group again, and I pay attention about children, nephrotoxic drugs and using in children, infants and young children with extracellular volume depletion, sepsis, renal impairment, cardiovascular disease, diabetes, or prior exposure to radio contrast agent are at risk of develop drug nephrotoxicity. It can be clinical presentation, the most common manifesting decline GFR leading to a rise in CCRBUN, malaise, anorexia, vomiting, shortness of breath, or edema. And decreased urine output may be an early sign of toxicity, particularly with radiographic contrast media NSAIDs and CAs, with progression to volume overload and hypertension. What we're talking about, I won't pay attention and on how diagnostic this condition. List of biomarkers of evolution of nephrotoxicity. It's I divided it like nephron segment. It can be on level of glomerulus, on level of proximal tubes, or distal tubes. When we're talking about glomerulus, drug-induced nephrotoxicity, it can be, and you see it on my slide, it can be C inhibitory, BNCH, metamycin C, proteinuria, antiplatelet agents, cyclosporin, quinone, albumin, transferrin, immunoglobulin, G-beta-2 microglobulin, alpha-1 microglobulin, cystatin, serotinol binding protein. Cytokines, when we're talking about proximal tubes, aminoglycoside, antibiotic, amphotericin B, adenovirus, cyplastine, contrastin, cocaine, heroin, forcanet, methamphetamine. It can be cytokines, interferon, interleukins, tumor necrotic factors, CCFAs, type 4 collagen, urinary proteins, enzymatic activities, alpha-GCT, and acetyl-D-glucosaminadases. It can be proteinuria, albumin, transferrin, immunoglobulin, GB2 microglobulin, alpha-1 microglobulin, cystatin, retinol binded proteins. When we're talking about ductal tube, it's amphotericin B and lithium can be cytokine, interferons, interleukin, tumor necrotic factors, CCFAs, KIM1, NGA, glusterine, stepantin, and you see these biomarkers. Please pay attention for these markers. Why? Because it can in the clinical trials it's important too, because when you include this in biomarkers, because for example even in stage 1, when you gain administered in healthy volunteers, this condition, drug-induced kidney injury, can happen. Laboratory test, a change in CR or at least 0.5 mg per deciliter for subject with a baseline CCR 30% for those with CCR more than 22 mg per day deciliter, when correlated temporally with the initiation of drug therapy, is commonly observed. Prevention of DIKD-DIN. Avoid the use of potential nephrotoxic agents, patient of increased risk and toxicity. Maintain careful and adequate hydration and establish with high renal tubular urine flow rates. Drug mechanism specific invention. General approaches for the prevention of AK: its avoidance of nephrotoxins, recognition of potential nephrotoxin agent, recognition of high-risk patient and clinical setting, avoidance of concomitant use of multiply nephrotoxin, use of lowest dose and for shortest time possible is applicable. Monitoring of drug dose, frequent monitoring of renal function, maintain euvolemia, minimization of nosocomial infection, extracellular fluid expansion, maintain good urine output, stable hemodynamics, avoid agents, stay impair renal blood flow. Autoregulation, NSAIDs, ACA inhibitors, RBS, pharmacologic intervention, if applicable, use of computer surveillance systems, identify high-risk patient and medication, determine correct dose for GVR. Formulas or assess renal function and all medication. You can use these formulas. Why? Because it can help you and assess renal function in stage chronic kidney disease. For example, MDRD, Cockcroft Gold formula, and you see this formula to adjust drug dosing for renal function in adults, and Schwartz to adjust drug dosing for renal function in children, because you remember this group are very sensitive for nephrotoxicity. And about general measures to prevent drug-induced nephrotoxic general, we will assume it adjust medication dosages using the Cockcroft Gold formula in adults or Schwartz formula in children. Access baseline renal function using Miller equation and consider patient renal function when prescribing a new drug. Avoid nephrotoxin combination. Correct risk factors for nephrotoxicity before initiation of drug therapy. Ensure adequate hydration before and during therapy with potential nephrotoxics, and use equivalently effective non-nephrotoxic drugs whenever it possible. Dear colleagues, thank you for your attention. I will be very thankful for your question, and we will continue our clinical pharmacovigilance lectures. I will be thankful for your comments in YouTube channel. Subscribe on my YouTube channel, because it will be help promote this channel, and many doctors, I am receiving questions from many doctors about needs. I will follow it, and what I want to do, I will when I finish my general question, I will go to, for example, pharmacovigilance psychiatry, pharmacovigilance cardiology, and we will go and talk about theory and practical cases. What I want to do, I want to make some practicum. For example, I received many questions about how conduct assessment and causality, assess causality in real cases. Why? Because it's one topic. What now I receive question another. It's very painful for medical doctors. I understand it because I medical doctor too, and with clinical experience, and I know how it's painful to recognize that you can make this mistake, but when you will find reason of this mistake, you will not repeat it in future, and your patient will stay healthy in future, because medication errors, medical errors, I received many questions how prevent it, how minimize it, and in future I will pay attention, for example, like in this lecture today for contrast media, on this risk factors, for example, and for example factors for skin influence on it too. Because when you understand it, you can give advice for your patient, and your patient will minimize risks, because you see that there is risk related with drug related risks, and there is group of risks, patient related groups. Thank you very much for your attention, and please follow my channel, follow my lectures, and again leave comments, subscribe on my channels, and see you later on my future lectures. Thank you very much.